out today and introduce our guest.
Great. Well, thanks so much. Great to see everyone out there. And we're still, unfortunately, physically distanced, but socially and virtually connecting through this awesome platform. PMD Alliance, thank you for continuing to host. So I've brought you some amazing speakers over the last, I think it's almost 6 months. We've had some of the Avengers on. We've started this energy and interest and sort of activism around not just local issues with Parkinson's disease, but also the global issues that are facing our own sisters and brothers out there in the world, on the planet, with Parkinson's as well. I've learned a lot learning about, some of the disparities just even within the US, and we'll have some speakers come on and talk about that. But I've really been, my eyes have been opened. We had Omotola Thomas and Rochelle Flanagan come on and teach us a little bit about Ireland as well as Africa. And it was really, mind-blowing to learn that there are many countries in the world where you have no access to some basic medications such as carbidopa-levodopa, that there's huge stigmas with this disease. And so we continue that, probing from more of a medical perspective, and learning about global issues, global healthcare around Parkinson's disease. And it's with great pleasure that I bring my friend Camilla Kilbane today. Camilla is now based out in Ohio, but we've shared some our paths have crossed many times. She is originally from Norway, from it's Trondheim, right?
Trondheim, yeah.
Just way up in the north of Norway, and then spent some time actually in Ireland, taking her medical training there. She won a scholarship, which she'll tell us a little bit about, to get some medical training, and then came out to the United States, spent some time at Sinai, doing her residency and her fellowship training at San Francisco with some of the speakers that we've had, and is now out in Ohio. She'll teach us a little bit about her journey, and hopefully shed some light on, because she's actually practiced in some different, or learned in some different settings around the world, and has really been interested in this sort of global issues in Parkinson's. So Camilla, and we've also connected through Women in Neurology group, which will be having some of the other members. I wanted to really bring some strong female voices out and highlight some of my friends as well across the country. So we'll be having a number of the women in the Women's Neurology group in the next month as well, sort of speaking around great topics that they've been advocating for. So Camilla, welcome.
Well, thank you. Thank you so much for having me. It's an absolute pleasure to be with you guys this afternoon or a midday, wherever you are in the world. So I'm really excited to be on this platform and tell you a little bit about Parkinson's in the rest of the world, and I'll hopefully have some discussion with Indu about the topic.
Yeah, so tell us a little bit about your journey. So what made you go into medicine? What made you move to Ireland? What made you come to the United States? Tell us a little bit about that.
Yeah, so, I think it's one of those situations where, if you asked me at 17, 18, did I ever think I would end up in Cleveland, Ohio? I would say definitely not. And so I think the world, your journey really takes you places, and things happen. And so I grew up in Norway, and my father was a gastroenterologist, and I always admired his work and seeing, like how much he loved his job and helping people. And so when I was about 18 years old, because in Norway, you don't go to undergrad, you go straight from high school to medical school. And the government had these scholarships where you could go study medicine abroad. The countries that you could go to: Germany, Australia, England, Ireland, Malta, Holland. And I was a die-hard U2 fan. So I picked Dublin as my first choice. I don't know if I thought I was going to meet Bono at the bar on Friday nights, but that's how that ended up. And that was the best decision I've ever made. For anyone who's been to Ireland, those are the happiest, most fun and outgoing people in the world, and I had a blast. And I met my husband to be there, and he's from the States, and so we were trying to decide, should we go back to Norway, should we go to the States? And we decided we'd go to America first, and I said I want to live in New York. And so we applied for residencies there. I did my residency in New York City, and then we're kind of, I would say, itchy people. We like to move around, and so we're like, let's try something else. And so we ended up on the West Coast. But he's from Cleveland, Ohio originally, so that's how the circle ends, I suppose, for now.
Amazing. So, what tell us a little bit about your love for Parkinson's disease and Parkinson's patients, because I know you're also doing a lot of patient education in Cleveland as well these days. So, tell us a little bit about that.
Yeah. So again, I think what this community shows is that, and this whole platform shows, is the strength in community, and learning from each other and supporting each other and knowing that you're not alone. And so I think that so in Cleveland we have this Parkinson's boot camp. Usually it's a one-day event that happens once a year, and it's a full-day event that focuses a lot on wellness, exercise, but also some updates about general topics related to Parkinson's disease from some outside speaker. Obviously, this year we weren't going to do that, and so actually Dr. Subramanian is giving one of the talks we have in our upcoming virtual lecture series. And so I'm really passionate about seeing the whole person with Parkinson's disease, and not letting the disease define you as a person. It's just a small part, but not the person. And so that's really important to me.
That's amazing. So maybe we'll link also your series so people can maybe join virtually if you have the space, and they can learn from everyone. So somebody's asking, if you go from high school directly to med school, what about education in basic sciences? Doesn't 4 years of pre-med give you the opportunity to get a well-rounded education? What would you say to that?
I would say that probably is a good, they have a good point. I think one of the pros of going in early is if you know what you want to do, then you're on your path. And part of 6 years of medical school is actually that the first year is what's called a pre-medical year, and that's really the basic science learning. So that's the biology, the chemistry, physics. And then from the second year onwards, that's when you start really the medical school training. I think the flip side of that, though, is that, when you're 18, are you really mature enough to make that decision? And I don't think everybody is. And maybe I was just lucky that I happened to stumble upon it, or like wanting to do it and ended up actually wanting to do it as a job afterwards. I will say that there were certainly members of my class who ended up not practicing medicine because, I think maybe sometimes you have to mature a little bit before you can make those kinds of decisions. But I think there's pros and cons to everything. Less student loans, there's different ways of looking at it.
Yeah, and I did 2 years of my undergrad, and I went to med school, and I was 18 too when I went, and I felt quite overwhelmed in some ways, but I thought it was, I had the energy and the excitement, and it sort of put me at an earlier stage. And maybe not all that science training makes us maybe a little bit more holistic in terms of our approaches, at the end of the day. And I feel like you and I are still learning, Camilla. Like I've done this whole integrative exploration, and I know you've been moving and trying new things and stuff like that. So I think, I think there's some benefits of all of the above, but I think, there's not one path to sort of.
Yeah, I agree. I think exactly. There's not one path. I think there's multiple ways of getting to your destination.
Absolutely. Well, let's start. Maybe you could teach us a little bit about your the slides. I know you have some slides, and you told me that you actually had learned a lot putting the slide deck together as well. So teach us a little. We'll sort of learn together.
Yeah. So again, I'm going to start sharing my screen here, and here. Let me start the slideshow. Okay, so again, I want to thank you, Indu, and also the PMD Alliance for allowing me to speak on this topic. Because again, I really do think that I've learned a tremendous amount going through all of the literature and about Parkinson's disease in various parts of the world. Just like Indu said, opening my eyes to the disparities that are across the world and the limited access to medications and more advanced therapies across the world, and not just pessimistically, but also looking at it from a very optimistic point of view, that there's a huge opportunity here. There's a huge opportunity for ability to improve access and treatment for people with Parkinson's across the globe. So again, thank you. I think also, it's important to remember we are all part of the same globe and part of the same humanity, and to maybe see if we can extend our reach out further than to our local environment. So I think it's really important to just talk about some of the definitions that the United Nations have put through. What exactly is access to healthcare? And what the definition is that's having medicines continuously available and affordable at public or private health facilities or medicine outlets that are within 1 hour's walk from homes of the population. So that's really what the United Nations defines access to healthcare. I also think it's important to talk about, even though we're talking about Parkinson's disease specifically today, but then to also talk about what is the life expectancy at birth for people born in different parts of the world. And there's a huge staggering difference. So in the United States, the average life expectancy for a man is 76 years. It's 81 years for a woman. In Japan, the average age expectancy is 84 years. If we're going to sub-Saharan Africa, the life expectancy is 62 years for a man and 64 for a woman. And the lowest life expectancy in Africa is found in the Central African Republic, where the average life expectancy is 49 years. Although these are pretty grim statistics, I do think it's important to note that since 2000, life expectancy in sub-Saharan Africa as a whole was only 53, and now it's gone up to in the 60s. So again, showing that there's a positive trend as well. So when we talk about Parkinson's across the world, just a couple of quick terms. So incidence is really a measure of new cases that arise in a population over a specific period of time. So when we talk about incidence of Parkinson's disease, we really are talking about how many people are diagnosed with Parkinson's over a period of a year, for example. And prevalence is just a measure of all the people who have a specific disease. So those are just some important terms as we go on. So World Neurology Statistics, so really the trends of what diseases are affecting people are changing. So the risk of having a stroke and having dementia, that's declined in North America and Western Europe. But Parkinsonism, ALS or motor neuron disease, as well as late onset multiple sclerosis, those have increased. But other regions of the world have very different social and physical environments, and they may have very different trends than what we see in kind of the Western world. And it's really crucial to understand this to better tailor treatments, which may be very geographically different. Another thing that's really important is, irregardless if it's a high income or a low income WHO region, neuropsychiatric conditions are the most important cause of disability worldwide. So it accounts for about 40% of healthy life lost due to disability. So that's both in high income and low income countries. So Parkinson's disease is the most rapidly expanding neurological disorder in the world, and the second most common after Alzheimer's disease. And in 2016, there were about 6 million people worldwide who had Parkinson's, and it's projected to be doubled by 2040. And the prevalence, so how many people have Parkinson's in a given part of the world, varies significantly. The main risk factor is aging. So the highest prevalence is usually seen in the countries that have the longer life expectancy in older populations. Most studies show that Parkinson's is most common in white populations. Men tend to be affected more than women. But interestingly, geographical locations tends to be a stronger determinant than ethnicity. So for example, if you look at the prevalence of Parkinson's disease in Black Africans living in sub-Saharan Africa, it is much lower than people of African origin living in the US. It's actually 5-fold increase in the US compared to sub-Saharan Africa. So quickly, US statistics, we're close to 1 million people living with Parkinson's in the US in 2020, and 60,000 people get diagnosed with Parkinson's every year. So in the world, again, 1% of people over 60 and 4% of people over the age of 80 are affected by Parkinson's. And we actually think that a half or 50% of people with Parkinson's in the world are not diagnosed and therefore not treated. And so that's a pretty amazing statistic right there, 50%. So that means 50% of people with Parkinson's are not getting the help that they need. And that is kind of a sad statistic, but again, on the other side, it's also a statistic that shows that, you know, we can make a huge impact if we try to change access to Parkinson's treatments across the world. All right, so this is just, we're not going to spend a lot of time with numbers and things like this, but this is obviously a picture of the globe, and it shows how the prevalence of Parkinson's disease is different across the world. So what you can see is that in North America, and specifically Canada and the US, and also in Argentina. Those are the parts of the world with the highest prevalence of Parkinson's disease. As you can see, the African continent has the lowest prevalence of Parkinson's disease. And then Europe, Russia, and Australia are kind of in the middle. So who has access to care for neurological disorders? And I think these are pretty astonishing statistics. And again, I don't want to emphasize a lot of numbers, but I do think this really hones the point down that there's a significant disparity in access to care. And so there's basically 0.03 neurologists per 100,000 people in sub-Saharan Africa. There's 5 neurologists per 100,000 in the US, and about similarly in Europe. So to take it more on the local level, so Cleveland, Ohio, where I live, there's about 2 million people in the greater Cleveland area, and we actually have more than 16 movement disorder specialized neurologists. And if you want to contrast that to a country like Tanzania in Africa, there's actually 1 neurologist per 10 million people. And if you look at Mali, which is another country in Africa, almost all of the healthcare personnel is located in the geographical area that represents 10% of the actual land, and where only 14% of the population is living. I guess you can say also some of that goes to the United States, where there's a lot more access to healthcare in people who live in urban areas opposed to people who live in rural areas as well. So first we're going to talk about, so we're going to take a little view of the world. So we're going to talk about Parkinson's disease in the Western Pacific region. This was a study that was published just a year ago in association with the World Parkinson's Congress in Kyoto. And basically there's an overall lower prevalence of Parkinson's disease in this area, even though there's an aging population, specifically, in parts of this world, including Japan and Singapore. What's also interesting is that in South Korea and Japan, it's actually female predominance instead of male, which is different. They have different mutations in common genes that we see in Parkinson's disease. And even though this area includes Japan, South Korea, Australia, and so forth, there are many countries there where there's a major gap in knowledge about Parkinson's disease. So for example, people may think that it's only Parkinson's disease if you have tremor, which is actually a common misconception, I think, not just there, but in the United States also. If you don't have tremor, it can't be Parkinson's disease. And also, you have to have a positive family history was a common misconception. Non-motor symptoms were really poorly recognized. And then the last thing was that 35% of people in Laos, Cambodia, and that area believed that Parkinson's disease was a curable disease. So also just the matter of, there's large populations that live in this area. So Asia will actually have 60% of the world population over 65 and older by 2030. And China alone will have 5 million people living with Parkinson's by that time, which is actually 60% of persons with Parkinson's disease. There's a large amount of research coming from that area, China, Japan, South Korea. But when you look at the Parkinson's related clinical trials, they're actually underrepresented, even though there's such a large population there. Only 20% of the studies that were used in the Movement Disorders Task Force to recommend treatment options were actually based in that area of the world. What's really interesting is that they're often using more complementary and alternative therapies like Tai Chi, acupuncture, herbal remedies. And there's probably a lot that we can learn about that and study. Levodopa is not widely available in some of these countries. And in general, patients with Parkinson's disease in this part of the world tend to take lower doses of medicines in general. So I really like this diagram that they have in this, because I think you can make this diagram for anywhere in the world. Just showing that there are different demographic and cultural factors. There are different psychosocial factors, there are different medical factors, and then there are different genes in different parts of the world which can impact the Parkinson's motor and non-motor symptoms, functioning, and also quality of life. So I know that whoever was here for Wednesday's talk I heard a lot about Parkinson's in sub-Saharan Africa, but I do think that was something I really wanted to touch on again a little bit because I think it's so important. Again, most of these countries don't have fall under the WHO, World Health Organization standard of having one doctor per 100,000 people. There's usually one neurologist per 100 million people or less. It's a very rapidly growing and young population, but still 5% of the population are over the age of 65. There's a very limited epidemiological studies from that area. And so when I showed that big picture of the world, initially, you know, the sub-Saharan Africa was all blue, meaning low prevalence, but that really is also because it's not been studied properly. And so the way you really diagnose, do epidemiological studies looking for Parkinson's disease is that you do door-to-door studies. And in a study in rural Tanzania, they actually found that 78% of the people that they actually diagnosed in this study had never before been told that they had Parkinson's disease. And so I think, again, it highlights that, you know, it's largely unexplored, and we also know very little about the genetics. And I think that the genetics that we often think about in Parkinson's disease are related to white Caucasian populations, and most studies that come from Africa, they have not found those genes, but there are probably other genes that we have yet to discover. So there's actually a lot of work that has happened and to try to improve our understanding of the prevalence of Parkinson's disease in Africa. First and foremost, you need to have an ability to screen people, and that means having the questionnaires translated into different languages. And so Carly Tanner is an epidemiologist, and she has made these 11 question or 9 to 11 question screening tools. And so here's actually a study where they translated it to Arabic, they translated it to French, and then they did this study in 3 countries, 1 Arabic speaking, 1 French, and 1 English speaking country, and showed that it was valid and reliable. And by having those 3 languages, having the screening tool translated into those 3 languages, that actually captured 78% of the population of the continent of Africa as a whole, actually. So, you know, really there's lots of strides to be made, but I think there's a lot of important work being done. So Nigeria is actually the most populous country in Africa. It's a multi-ethnic country. There's actually more than 500 different ethnic groups within the country. Currently, it's the 7th most populous country in the world, but in the next 20, 30 years, it may become the 3rd most populous country in the world. It's a rapidly growing population. So again, with that amount of population growth, you can imagine how many people are actually at risk of developing Parkinson's disease. So again, a lot of wonderful work being done here. This is the Nigeria Parkinson's Disease Registry. This is a physician-driven registry where physicians will register the patients at they diagnose. And thus far, they have almost 580 patients registered. And in addition to being a really important epidemiological research tool, this also is a great portal because it allows patients and people to access the registry and find a neurologist that can take care of them in their area of the country. So it has really a dual function, and it's a research tool, and then it's also a patient tool to improve help and care for patients with Parkinson's in Nigeria. So again, 50 to 100% growth in number of persons with Parkinson's by 2030. So you can imagine there's a lot of need. Another thing that's interesting, and I think again, it is, although not to this extent, there's really a difference in access to care between urban and rural areas. And I think that goes for any part of the world. I think it's different if you live in a metropolitan area or a big city like LA or New York, where there's multiple universities and competing centers from different medical centers, versus if you live in a small town in Idaho. The access to care is very different. And this is also obviously the same in Africa. And this is a study from Cameroon And basically, they compared a rural area and a urban-based medical center. And basically, patients with Parkinson's were only diagnosed in the urban centers. There were none diagnosed in the rural outpatient departments. So again, this goes to maybe limited access and also need for more education of healthcare personnel. Let me see here. Okay, I'm going to space. So the other thing that's interesting, again, and I'm not going to harp on this because the speaker on Wednesday really spoke so much more eloquently about this than I ever can. But there are really some challenges to care and research for people with Parkinson's in Africa. As I think I've said multiple times now, there's not enough neurologists or physicians. There's also a delay in diagnosis and treatment because traditional medicine is often the first step, especially if you live outside of urban areas. I think as our speaker on Wednesday really spoke about, stigma is huge, and the perception that the disease might be caused by a curse or by a bad omen. There's low rate of health insurance coverage, and there's also often a denial of a positive family history because this may impact the image your family has within the village or within your community. So let's talk about access to drugs. So this is from the World Health Organization again. So drugs for Parkinson's are only available for 3% of those who need them in primary care in Africa. 3%, 3 out of 100 people. In contrast to about 70% in Europe and 34% globally. And when you talk about what the medications they're actually referring to, they're talking about 2 drugs, levodopa and anticholinergic. So those are the 2 drugs that are on the essential medicines for Parkinson's disease, according to the WHO. So, you know, medicines that we often use here in the United States, like MAOI inhibitors, rasadolene, tacopone, dopamine agonists, they're not even on the list of essential medications. And often 1 month's supply can cost more than a combined household monthly income. And then there's also likely a huge difference between how available these drugs are in the urban setting and in rural areas of the world. So here's a study looking at access to medicine in Kenya, and levodopa was only available in about 50% of the pharmacies. And anticholinergic, so it's not very often used here, like Artane. Sometimes it's used for people if they have tremor, if they have dystonia in the United States. That was relatively frequently available. And then also some of the older dopamine agonists that are not really used very frequently in the United States, such as bromocriptine. The mean cost of 100 levodopa tablets was $48, and that's a huge amount. This is also, again, very similarly showing that medications are not widely available. Levodopa was available about 56% of the time. And again, it's not only that levodopa is available, there's different formulations of levodopa. There's the 25/100, which is the most commonly used medicine in the United States. But then they also come in a 25/250 formulation and the 10/100. And it was usually this higher strength 25/250, which is available in Africa, or the 10/100. And obviously that can lead to complications because you're more likely to become nauseous when you have less of the carbidopa in the medicines. And again, the average cost of the drug was $40. So I'm not going to talk about all of this in detail, but just to show that this is not just in Africa that medications are expensive. A study from India showed that people spent about 20 to 40% of their average gross yearly income to pay for medicines for Parkinson's disease, and similarly also in China. This is interesting. There's a study going on in Tanzania, actually. So MUCUNA PRURIENS. I actually have patients who do take MUCUNA supplements, and this is a levodopa-containing crop that grows naturally. And it's actually been studied in Tanzania and has been found to be helpful in other studies from Ghana and Bolivia as an add-on or even as a monotherapy. And since Tanzania makes a lot of coffee, it's going to be roasted and ground on the hospital premises, and they are going to try to use this crop to supplement levodopa because the actual drug is not available. So we all know that Parkinson's disease is not all medicines, right? There's so much more that goes into taking care of your health. And so there are many, we really like to think about Parkinson's care as an interdisciplinary model, which has a lot of involvement from occupational therapy, physical therapy, social work, speech therapy. And as you can imagine, in places of the world where there's very limited access to medications, there are also very limited access to other treatments like physical therapy, occupational therapy, and so forth. And in addition, there can be other specific barriers, such as, for example, in the Arabian world, if you're a female, you may not be able to go to the physical therapist without having a family member accompany you, and so forth. So there's a lot of different psychosocial and cultural things that can also play into barriers for care as well. So if you don't have access to medicines, you're not going to have access to very easily to deep brain stimulation. And again, you know, in the US and in Europe and specialized centers, about 5 to 10% of patients have deep brain stimulation. And as you can see here from the graph, the access and the availability of this treatment is very different across the world. You know, I read a statistic that if you were to have DBS in the Philippines, for example, it would cost the family on average 7 to 11 years of that family's income to be able to afford the deep brain stimulation surgery, for example. So 10 years of life income to pay for that surgery. And so obviously there's a lot of, and I also, I'm using Medtronic. This is a slide from Medtronic actually, just because that's the manufacturer that has made DBS for the longest. And I was able to contact Medtronic and ask them, and they said they've done in total 1,000 DBS implantations on the continent of Africa. So again, you know, usually there's about 5,500 annual implants in the world. So that's a very low number. But of course, this is because there's not enough physicians. So there's 0.01 neurosurgeons per 100,000 people in Africa, compared to 1 per 100,000 in Europe. There's a lack of neuroimaging. There's no neurosurgery service for Parkinson's patients in Nigeria. And so there's obviously a lot of barriers to access to more advanced therapies. So there's a lot of numbers in my talk, and I hope I haven't bored everyone with it, but I do think it's important to kind of get the numbers to really understand how different it is across the world. But enough of that. I think, you know, COVID has upended everybody's life and has really been a challenging period for everyone. But I thought I would mention something that maybe on a global perspective might be a silver lining, for example. So with that in mind, so the International Parkinson's Disease and Movement Disorders Society has about 10,000 members. And of those, you know, the majority are from the European or the Pan-American section, but there's about 8% from Africa and about 30% from Asian and Oceanic section. So Indu and we all look forward to our annual Congress. It's a great way to learn and to meet our friends from across the world. And so obviously it was a little bit sad that we couldn't do that this year, but the silver lining is this. So 20,000 people registered, which is so much more than you'll see in the next slide. 146 countries were represented. It didn't cost anything to attend it. You could watch the lectures live, you could watch them on demand. And so obviously this exposes a lot more of the world to learning about movement disorders and Parkinson's disease. And so again, I think this is a silver lining right here. I think that this is a wonderful thing that allows more people to have access to learning about movement disorders. And hopefully they will keep some virtual presence in the future as well. Just to compare, the years before there were 6,000 in Nice and 4,000 people in Hong Kong. So 3 times more than Nice and 5 times more than came to the Hong Kong Congress. So lots more people are learning about Parkinson's disease, and that can only be a good thing. So other efforts, so the Movement Disorder Society have a special track or a special service where they can support different, projects to improve access to movement disorder knowledge across the world. And so there's a telemedicine task force with the Movement Disorder Society, and they have done a lot of work trying to do tele-education programs for healthcare providers. There's been a program in Cameroon. Esther Kubo emailed with her, and she thinks she's trained 60 people at this point. And they're not just neurologists, because I think since there's so few neurologists, we need to improve access across many types of doctors, many types of healthcare providers. And so I think she has trained nurses, primary care physicians, medical students, and psychologists and neurologists, and had this tele-educational program for healthcare providers. She also did the very similar thing looking at medical students who maybe didn't have access to movement disorder specific training. And this was a project that was done also in Cameroon and in Argentina, and again showed that this was possible and had good results, and again can spread knowledge across a much broader part of the world. And so again, Zoom is not, Zoom has really taken over our life, but there's good things, and especially for me, I think telemedicine was something that was not really that much on my radar before COVID-19, and it's kind of changed my outlook on the possibilities that this really has for us as providers, but for the greater community also. So we want to end on a positive note here. So this is another really cool consultation service called the Asynchronous Consultation Movement Disorder Service that was started in 2017. And this basically offers virtual consultation for movement disorder cases from members of the Movement Disorder Society. And so what's really great about this is that, for example, in many parts of Africa, they have slow internet or coverage, or they may have electricity outages. So doing, a synchronous talk like we're doing now online with Zoom may not work. And so what this basically does is that they can upload a case, store and forward it, and then you have consults from doctors in Canada, United States, Israel, and Spain, who will review the case and then give their report back to the local referring provider in Africa. So they've had cases from Nigeria, Ghana, Egypt, Congo, Madagascar, and Burkina Faso. And this is a project that's led by Dr. Mark Gutman in Toronto. And I first learned about this when I was in Nice, and I eagerly joined the list of consulting neurologists. I haven't had my first case yet because after COVID-19, I think there's been other issues and less cases have come through, but I think this is a wonderful way of sharing knowledge and allowing for consultations with people who are living in remote areas of the world. So I'm almost at my end. So I also wanted to highlight some of these wonderful organizations that are out there. This is a Canadian program, lots of good things from Canada. And this is a nonprofit aiming at providing free medication, education, and walking devices for patients with Parkinson's in the world. This was started by Dr. Rana in 2008. So far, they have given out 50,000 copies of educational programs, 5,000 patients have received free medications, and they have had services across 39 countries globally. So again, I think a wonderful program that I learned about researching for this talk. And now I have a Zoom meeting with them in the week, and hopefully we'll start a chapter and become an ambassador here in Cleveland. So again, thank you for inviting me. I think I've learned a ton from giving this talk. Again, there are so many amazing organizations, and I'm sorry for highlighting a lot of more the African side here. But these wonderful organizations across the world here: Parkinson's Africa, African Parkinson's Disease Foundation. There's this International Parkinson's Disease Genomic Consortium, which I think is so important. It's not just in Africa, it's in South America. Again, most of the genes that have been described until now have been focusing on white and Caucasian people. And I think, we need to learn about the genetic component of Parkinson's disease across the world. I think learning about this will help all of us and put the puzzle together about how we can move our treatments forward. So I want to thank all of the amazing people with Parkinson's, organizations, healthcare providers, family members, and loved ones for keeping up the good fight. I want to thank Indu for having me talk today. And I also want to give a shout out to our incoming fellow who's coming next year, Dr. Temitope Laval. He is in Oklahoma and he is from Nigeria. And he's doing his neurology residency at Oklahoma University, but he's originally from Nigeria. And he's actually been involved in some of the work that's been done in Nigeria. And we hope to continue doing some work, more global work, when he comes to join our program. That was all my slides.
Wow, that was amazing. Camilla, you did such a great, thorough job. Wow, like literally to the cutting edge moment. We just finished the MDS and you got all these statistics, which is amazing. Maybe we'll just stop sharing slides so we can see your lovely face.
Yes, hold on. Let me see here, stop. I think I kind of, it's one of these things where I kind of went down the rabbit hole and I kept finding more and more things and I didn't exactly know how to end.
No, I think that's amazing. So, so I think, oh, okay, well, there's some very sweet comments. One is from Bobby. I want to thank Camilla for the wonderful downtown panorama of Cleveland, my hometown. It brought my but there's also a lot of people who are saying, I think one of the comments was, I think sometimes it's like, this is sad, I hate to be selfish, but, from a, other than a humanitarian point of view, why should we care about other countries when we also are suffering in the US? But I think a lot of people have said, in response to that, that humanitarian perspective is very important. And that, often when we start looking at this, developing a global perspective in addition to a solely altruistic purpose provides opportunities for the PD community at large to share knowledge and build a stronger leverage base to push for changes in terms of improved research, access to alternative treatments, et cetera. So I think that is, one of the things that the Avengers is really trying to push is sort of these global voices. And I think for me, one of the silver linings and sort of an awakening in some ways, when COVID, was coming our way, it started in, the East and then Italy, and we saw it in New York, and it was coming towards Los Angeles. There's this sort of sense that we are all so globally connected. And I think, a virus that starts, across the world can affect us. If I wear a mask, I can affect my safe, sending something your way or not, so I think we're I feel like the connection globally and even in my own community, has been heightened. And I think even, Claudia, as our, the president of the Movement Disorder Society, came on for World Brain Day and highlighted, Parkinson's is like the diagnosis of this year. It was amazing when we see these statistics that it is growing. It's growing across the world. It's happening, in all these communities rurally. We probably are not identifying a lot of the cases, even in the US, honestly. That, simple low-hanging fruit that we had talked about, I really think that, some of the ideas that you've had and we've been feeling kind of within us to do something could make a difference for not just the people in Africa or Asia, but, if we create some videos, can translate them into languages, just talking about disease awareness. And, this is not, something that is transmitted from person to person. It's not something that, a witchcraft situation. It is something that is a common disease that we have, treatments for, that we need to get people identified and presenting to the right places. So I think, that educational piece is absolutely huge to build disease awareness. And I think if we can understand what other countries are doing that work, as you mentioned, the complementary alternative medicine approaches in some of these Asian countries, there must be something that, we can translate even to our own, sort of backyards here.
I agree. I think there's exactly 3/4 of patients use those kind of remedies there. I think that's an opportunity for us to learn a lot. You don't have to reinvent the wheel. People have been doing this for thousands of years. So, there's tons to be learned from people across the world. And again, I think everyone holds a piece of the puzzle, and it's not until we all put them together, I think, that we can really understand fully how to, it's like, the alpha-synuclein gene was found in one Italian little family. And so that's not everybody, but You know, we don't know what we can find when we look at different populations that could impact everybody. So I think, you know, I do think it's really important to, even in addition to the altruistic and the humanistic, to really feel like this can impact all of us.
Yep, absolutely. So a couple questions, Camilla. So one is the African lower numbers. Is this because people are not diagnosed? Is that your sense? Yeah, yeah.
So I think that is, I think most likely it's very underdiagnosed. Is it as high as in the prevalence as high as in the US or Europe? I can't say, but I think a lot of it is underdiagnosis for sure. And the smaller part of the population being older because of the life expectancy.
Yeah. And then there's also some questions about Japan as, you know, case, you know, a test market or a place, you know, a place to look at, you know, why the incidences are more in women, maybe less, you know, sort of prevalent there. So what is your sense of that? Because I think that there's a decent access to healthcare in many of these places in Japan.
Yeah.
Is there something, do you think, in the diet is one of the questions or something else? What's your sense, just having looked at the literature there, of why there's less Parkinson's there?
Yeah, I think diet was one of the things that was brought up. I think also smoking is actually a part, because obviously, although we don't want anyone to smoke, smoking tends to be a protective factor for developing Parkinson's disease. And so those are kind of the two main things: diet, and then also, you know, comorbidities, right, like diabetes and things like that.
And I think, you know, from the diet, people are asking if there's been specific studies looking at diet in Japan. I think they tend to eat, you know, there's more of that, some of the Mediterranean kind of foods as well, you know, the sort of the emphasis on if you're going to eat meat and stuff, like they tend to eat more seafood, you know, more sort of healthful oils and things like that are omega-3. So I think those are, you know, some things possibly in the diet, but I think, you know, they often, you know, from a healthy lifestyle perspective, they're walking more in some of these places, and, you know, they tend to rely less on cars in some of these places. So I think a lot of lifestyle may have something to do with it, and longevity is really longer there. So it's really hard to know, but I think, you know, it merits, I think, some deeper dives in looking at it.
Absolutely.
And I think, you know, just to echo your thoughts on the Movement Disorder Society, I think, you know, many of us travel far and wide and get babysitters and, you know, try to get to this meeting historically. And, you know, it's been such a beautiful mingling of people from literally all over the world. You could be sitting next to a group that's from, you know, the opposite side of the world and start a conversation and start talking about things. And it's been so eye-opening, you know, for me to connect with this global community. And I'm just really proud to be, you know, part of that. And it's, you know, been a beautiful thing. We've had people because of that on this series from England and the UK, and Oscar Gershanik's going to come on from, you know, South America. So I think we're really, you know, hoping to expand our horizons. And I think it's beautiful that there sort of is this real mission of improving the care of movement disorders and, you know, Parkinson's patients across the world, not just, you know, the one patient that we might be seeing in our clinic, with the hope of, I think, making it better for all. But I think, you know, there is some possibility to really impact sort of things right here. Somebody else mentions green tea, possibly, seaweed, fish, possibly. And then, you know, there was a question about the smoking. So Camilla, do you want to just comment a little bit about your take on the smoking piece? Because people have asked a little bit about that.
Yeah, so, you know, caffeine intake and smoking have really been the two kind of substances that have been associated with a lower incidence of Parkinson's disease. That being said, no physician is ever going to recommend you to smoke because of the detrimental effects it has on your health otherwise. So caffeine, I'm all for, and I think I must be super protected. I drink like 4 or 5 cups a day, but yeah, right. But there have been quite a few epidemiological studies showing that smoking reduces your risk of Parkinson's disease. But again, because of all of the detrimental health effects it has, that's not something we recommend. I see here not Irish tea, by the way, underneath. That's funny.
So we have a cute audience. So Jane says, so thankful for the global outreach being done to improve treatments and access to care that groups like the World Parkinson Program is doing.
Yep.
Our definitely interconnected. And I think the Avengers and somebody's Sheila here has linked that. I mean, one of the things that I've noticed, and you probably noticed that seeing that video that I sent you from Wednesday, and we urge you to watch some of their programs. You know, they're literally all over the world, the Avengers, and they've come together, and energetically the you know, they each have Parkinson's, but have taken that diagnosis and at some point sort of taken that and pivoted to really giving to someone else as sort of a part of their mission. And I think that's really helped them feel better. And I think what I do some research in things like social connection, loneliness, volunteerism, being a volunteer and helping somebody else with something can give you tremendous purpose and actually improve a lot of your health outcomes in a huge way, probably more than any pill that I could, you know, easily prescribe for you outside of levodopa for sure. But, you know, really not, you know, there's not an antidepressant that I can prescribe. There's not a, you know, a sedative that I can prescribe that's going to be as powerful as using that, you know, sort of human connection to really help another person. So I think one of the things that I've really been finding kind of hugely eye-opening for me, you know, I work at a VA, run a center of excellence. I fight a fight every day for our patients to get something covered or, you know, get, you know, a walker for one of our patients. But, you know, when you see people having to walk an hour just to get water, to get, you know, having to travel, Omatola had to travel to England just to get a confirmation of her diagnosis 6 years after she, you know, started having symptoms in Africa. You know, these sort of just these stories of the woman that they described who was thought to be possessed and locked in a room, you know, just food inserted down there. She's not exercising. She's not exposed to, you know, so the sort of adversity that people have, you know, and are still able to sort of get up and fight, I think is what I've really been struck by. So I think this is a really beautiful talk to sort of end out the sort of Avengers, because I think, you know, I'm glad that people are bringing up like, why should we care about, you know, what's happening across the country or across the world? But I think we have really a sense that, you know, that there is something that we can all learn from this. So somebody writes, maybe that's the Japanese reason. They're culturally very altruistic. And then Norway has a pretty high happiness factor, right? I think some of these,
yes. It tends to be Denmark and Norway rivaling it out for the happiest place in the world. So yes. So I mean, I think the reason why that is because there's I think there's a really, yeah, that's it, I'm moving. I'm loving these comments. I think that there's a very good balance between work and life. I think, you know, there's always this saying that Americans live to work and Europeans work to live. And I think there's definitely something to that. I think that there is a sense of community and belonging for the population. And so access to clean air and the outdoors and exercise and all these things, I think impact the happiness. And I think also in general, you know, a community or a population with less gaps between the very rich and, you know, a bigger middle also, I think, has something to do with it.
Yeah. No, I think those are all things. I mean, I think the connection with
forest bathing.
Huge. Yes, forest bathing. Literally, like the connection with nature. So I think to take away from this on the weekend, y'all can have a coffee, meet a friend.
Don't smoke.
Don't smoke. Meet a friend and go for a walk in the forest. Maybe volunteer on the way back to pick up something for your neighbor. And, you know, and I think, you know, learn more about some of these other countries and what they're missing and how to get involved. Maybe sign up for the Avengers as well. One comment just about the MUCUNA. So MUCUNA, I think, you know, I have this background in integrative medicine. People always ask me about MUCUNA. And I'd love to hear from you as well, Camilla, but I'll just give you my two cents. I think, you know, MUCUNA is basically levodopa in this sort of bean that they have to boil and kind of prepare. But what ends up happening is that it doesn't have the carbidopa, which is in you know, the Parkinson medication. So I think for those of you who have access in the US or anywhere else to levodopa, carbidopa in that Cinemet, definitely much more easy to regulate. We believe absolutely that levodopa is an important drug. It's so interesting that some of these countries, you know, have only 25 250s, which is a horrible, honestly, combination.
Right.
So really, we have to, I think, push for getting just good levodopa if we're going to give it, 25 100s, with a good amount of carbidopa for every amount of levodopa. But I think, in these countries where they have no access to medications, or very little access, you have that carbidopa maybe in a pill that you're taking, 3 times a day, but you need more. Supplementing with that MUCUNA makes some sense, but I think we're not really telling people to go out there and try to, it's a tough thing to try to produce this equivalence and regulate it easily, if you have access otherwise. So
yeah, no, thank you for clarifying. Exactly. I was not recommending that. I was just kind of showing what kind of problem solving, they have to be smart, try to problem smart and work with what you got, right? And so that's what they're doing. But yeah, I would not recommend it for us in the United States. Yeah.
So I think, I'm just going to pull out just a couple of the things that were most striking to me from what you just said. One was the, 50% of PD patients worldwide aren't even diagnosed with Parkinson's. So I think, getting awareness to places that need it, breaking down those barriers. So I think, like you said, not just aiming for the doctors or the movement disorder, with the one movement disorder doctor in a country with 1 million. We have to get to the healthcare workers, even if it's the village, whatever, medicine man or whatever they call it in these places. We have to teach them maybe in a small video about the fact that, Parkinson's can affect everyone in all ages, men, women, it's something that, is common, and that they need to look at it. And this is what, it looks like, and this is what they should do when they find it. So I think, awareness, that was a striking statistic. The complementary alternative medicine use in these countries was interesting, and I think something to be learned from. And then this whole sense that, these door-to-door studies are uncovering a lot of patients. And so, the sense is that, they were asking about registries and stuff, but if you don't even know what you're looking for, it's hard for people to come forth and say, that they have it. So we're really probably missing a lot. And even in the US, I think, one of the statistics that I've been struck by is that 50% of patients in the US don't see a neurologist for their care. So even, in our own backyards, there is a huge gap between who's providing care. And so we need to get these educational tips and hopefully through videos like this, and getting the word out, which is sort of what we're trying to do here, and hopefully we can share these around, even if you have people in your community that are trying to, help with the care of these patients. You're welcome to send them links of any of these videos. The Movement Disorder Society has some links as well. But, I think we just need to kind of forget about the notion that it's going to be a neurologist or a movement disorder specialist. We just have to figure out how to, help primary care doctors or providers, nurse practitioners, PAs, nurses, whoever, is out there with the patient. So tell me maybe a little bit, just a couple of words of final hope. You really did shift that sort of the statistics conversation in your talks with a bit of doom and gloom, with the silver linings, but maybe just give our patients out here, we have a couple minutes left, Camilla, just a few words of hope and inspiration from your angle as a Parkinson's doc out there in Ohio, sort of your, sort of few closing comments here.
Yeah, no, so yes, so I guess, it is a little bit of doom and gloom in the first statistics, but again, I think we had to flip it around and look at it as a huge opportunity. And so that's what I'm kind of walking away from, having done this, done all the research for this talk, is this tremendous opportunity we have for globally for improving care for patients, people with Parkinson's disease. I think that, again, all of these wonderful web-based meetings, and this COVID having forced us all indoors, but connecting through our virtual environment, really has brought people across the world much closer to each other, has opened up access to learning about Parkinson's disease to people and healthcare workers who maybe didn't have access to it before. And so I think we're learning so much about Parkinson's disease in different parts of the world, and researchers are working so hard on finding, new treatments. And I feel very hopeful. I think within the next 5 to 10 years, there's going to be some dramatic changes. And for me, I think space is the outward limit, right? And the brain is the inward outer space, I feel like, where there's so much unknown still. And that's why neurology is so fascinating, because there's so much to learn still. And I really think that we're making huge strides, and that will move the field forwards. And I think people with Parkinson's play a huge part of that. And the advocacy and all of the, groups you're taking part in, and all the exercise classes you're doing, all of this is all part of moving care and treatment forward.
Absolutely. Well, part of my hope with this series was to have people feel like they could connect with some of the doctors that are out there, some of the providers that are out there, some of the researchers that are out there that are, trying to fight this fight and help the, move the path forward, and see us sort of in the humanistic way. And I'm just so proud of you, Camilla, and so many of our colleagues and friends out there, because I think we are working together to really make a difference, in our own communities, but also globally. So I'm just so proud of this lecture that you put together. I know it was a lot of work, but I think it was really beautiful. So I really appreciate you joining us, and miss you. Hopefully we get to
thank you. You too. I think the thing that always comes back to going to the conferences and doing this is that you actually end up feeling energized, right? I think you can get stuck in the grind of things, and sometimes these are the things you need for resetting the button and moving forwards and onwards. So thank you, Indu.
Yeah, absolutely. So back to you, Andrea, or Becky. I'm not sure who's closing us out with a goodbye wave today, but thanks again, Camilla. I appreciate it.
Yes. So Dr. Kilbane, we always end with a gratitude wave. So I invite everyone to turn on their cameras and send the love to Cleveland, and then we'll send it over to Norway, and then down to sub-Saharan Africa. So it was lovely spending time with all of you. I learned so much. You guys had great questions. So thank you. And we hope you join for another program.
Thank you.
Thank you.